Hello, everyone. Welcome to today's live broadcast. Here from the experts, COVID-19 and cancer care for patients. I'm Dr. Saad Usmani, Chief of the Plasma Cell Disorders Program and Director of Clinical Research in Hematologic Malignancies at the Levine Cancer Institute in Charlotte, North Carolina. And I'll be your moderator for today's event. We are pleased to bring you this webcast presented by Cure and sponsored by Janssen and Pharmacyclics. Before we begin, we have a few important announcements. This webcast is designed to be interactive, and we would encourage you to ask questions during the event. You can submit those questions by typing in the Q&A box, which can be found on the left side of your screen. You can enlarge the video by clicking on the small square icon in the upper right hand corner of the video window, or by hovering your mouse over the lower right-hand corner and dragging the window to the desired size. If you have any technical problems viewing or hearing this presentation, please click on the question mark help widget in the docket at the bottom of your presentation window. Let me begin by introducing our esteemed panel. We are pleased to be joined today by Dr. Zainab Shahid, who's the Medical Director of Bone Marrow Transplant Infectious Diseases at the Levine Cancer Institute in Charlotte, North Carolina. Dr. Farouk Aban, who's the Director of the Lymphoid Malignancies Program at the Harold C. Simmons Comprehensive Cancer Center at UT Southwestern Dallas, Texas. Dr. Ian Flynn, who's the Director of Lymphoma Research Program at Sarah Cannon Research Institute in Nashville, Tennessee. And Dr. Lee Greenberger, who's the Chief Scientific Officer at the Leukemia Lymphoma Society. Thank you, all of us, for joining today. I would like to start off tonight's live session by calling upon Dr. Shahid to kind of give us an overview of the COVID-19 pandemic timelines and how it evolved from Asia and how it got to the United States. And then, just highlight some of those data, timelines, and maybe talk a little bit about the common presentations as well.
Thank you, Saad. Good evening, everybody. Thank you for everybody who's joining us tonight. Today we are reaching a staggering number of more than 2.5 million cases around the world, with more than 800,000 cases in the United States. The history of the pandemic started in late November as we traced back it to China, and our first case came to our attention in the U.S. earlier this year in January. We have now more than 45,000 deaths in the U.S., and the numbers are increasing. Initially in the U.S., we were hit at West Coast, followed by New York City, New York East Coast, and then we started to see the disease spread as where the travel is in different areas of the U.S. With the increasing number, we started to see certain risk groups affected by the disease. I would say we're lucky in a way that we started to receive some early reports from China and Italy. By that time, we were starting to understand and try to handle this in the U.S. We are currently seeing that this disease is affecting the elderly still, ones with more comorbid conditions such as cardiovascular disease, pulmonary disease, diabetes, hypertension. We also know that this disease is affecting people of color and people with low socioeconomic status within the U.S. Most common symptoms that have been reported and that sort of have been similar in different areas of the world are fevers, followed by cough, shortness of breath. GI symptoms have also been reported as a presenting complaint of COVID-19. Nausea, vomiting, anorexia, and diarrhea have been associated. It's also been marked by myalgia, severe fatigue, and in an elderly population, it also is known to cause changes in mental status. So we are learning more as we are increasing our numbers. We are learning different presentations. We are learning different risk groups that are more affected by this illness. As we start to see a plateau in our curve within the U.S., we are starting to think that we are, with the increased testing, are able in the near future to go to what we call closer to the norm that we used to know. Social distancing has gone a long way in trying to flatten this curve. So based on the numbers that we have today, considering where we were to where we are today, we hope that the numbers are stable and continue to stay stable, and then hopefully in the near future start to decrease.
No, thank you, Zainab, for that nice answer and summary. I actually want to probe you a little bit about this this curve that everyone keeps on talking about. What does this curve mean? This bending the curve. Does it mean that we can cut this COVID-19 pandemic off off at the pass? No more cases will be seen after we, bend this curve, or what does this really mean? Was this a way of trying to make sure that our healthcare system does not get overwhelmed? Does it buy us time? What is this whole, bending the curve all about? You also mentioned social distancing in there as well. So if you can just, tell our audience, patients and caregivers a little bit more about that.
That's a very interesting question, a very timely one. When we were starting to get hit with COVID-19, there was this talk about in social media, flatten the curve, flatten the curve. What it truly means is that what we are trying to do as the COVID-19 spread within our communities, the number of cases are spread out over time as opposed to people presenting all at the same time. Because if people were to get sick all at the same time, that would strain the healthcare system to a point where hospitals are unable to take care for the ones affected by COVID-19. As we know that in areas where there were no flattening of the curve, field hospitals had to be built. There was shortage on ventilators. There was inadequate PPE for the healthcare workers. So what we talk about flattening the curve, what we are trying to do is decrease the spread by utilizing social distancing as the major tool to prevent the spread so the healthcare system is not strained. Now, social distancing is very important at this time where we now see that the curve has flattened. Because when we're going back to what we call normal, when we believe that now that we have flattened the curve, now is the time to go back to normal, the schools be in session, we get back to our daily way of life, that's where we are at risk of bringing the peak back again. So social distancing has played a major role in areas where they were able to flatten the curve. But as we talk about normality, we have to keep that social distancing or back to norm has to be a stepwise approach.
I think that Zainab, you make very pertinent points, and for patients with cancer in general and blood cancers, hematologic malignancies specifically, they're already cognizant of the fact that their immune system is low, they're immune compromised, so they're already careful, in times of the high surge of viral infections to be careful, and that I think you bring. A very important point here. And I'm going to turn to Dr. Farooq Awan and ask him how the COVID-19 pandemic has changed your clinical practice, the workflow, but for both physicians as well as nurses in taking care of your patients. You can be as elaborate as you want to. Feel free to cover any treatment recommendations or changes that you're seeing for CLL patients as well as for your lymphoma patients.
Yeah, thank you, Saad, and good evening to everyone. I think we're all learning. You guys said it already. This is something that none of us have experienced before. So we're learning more and more about the virus with every passing day. There's more data coming out. There's a lot of data, a lot of new data, a lot of new clinical trials happening. So everything's happening all at the same time. And we're all trying to do the best we can to decrease the spread of this so we can better manage our patients who do get infected. And that would not overwhelm the system. So in line with that, every institution has instituted a policy that suits their needs. And fortunately, in Dallas, we started with the social distancing early, and I think we were able to keep the numbers fairly manageable. And we still had to make a lot of changes to the way we practice. Now, with regards to outpatient management of patients, we have limited the number of visitors that come with the patient, family members and or other people who drive the patients back and forth. We try to keep them outside of the clinic area. We also have tried to make most of our visits electronic visits so that the least number of patients get exposed to the staff and vice versa. Similarly, we've also started utilizing local labs, which are a lot of times not as busy as the oncology clinics and cancer centers. And those labs then give us the results from the blood work that we need. So I think we've utilized all of these approaches on the outpatient side. We've also been fortunate that we have a service for drive-through testing for patients who have active symptoms. We are all trying to get them through the drive-through testing, and if they are positive, then they're asked to quarantine at home. For patients who do get really sick and need to go to the hospital, the ER has a system where everybody gets quarantined on arrival. They get tested in a rapid manner with a rapid test for their COVID-19. And if they are positive, then they are sent to a specific isolation floor specifically meant for those patients. So there are mechanisms in place, both on the outpatient side and on the inpatient side, which have tried to minimize exposure to patients, family members, and staff at the same time. So those are just some of the efforts among many that we have done. And we have used all of these resources to minimize the spread. Now, with regards to specific patient populations, and obviously I'll focus on the CLL and lymphoma patients very briefly. Fortunately, as far as the CLL patients are concerned, a lot of our patients can afford to wait a little bit to start their treatment. For patients who are not actively getting treated, we do plan on delaying their treatment until at least we have some idea of better treatment modalities. And if their symptoms can be managed by other approaches, we are trying to do that. For patients who are on active treatment, we are trying to continue those treatments, and we are trying to minimize their return visits, and we're trying to do that electronically as much as possible, either via telephone calls or through a video visit. Either option is being utilized so that they minimize their back and forth to the clinic. So that's for the CLL patients. With regards to the inherent nature of the CLL patients, we know that our patients with CLL are especially at a high risk of getting infections. Infection-related complications are one of the leading problems in our patients. So we expect that our patients would be at an extremely higher risk, and that's why we are also advising that they socially distance themselves from any known patient or persons who might have the virus. We're now also learning that there is a fairly large group of patients or people in the community who would have asymptomatic disease, and they can potentially spread the disease to a lot of other people without even knowing that they have the virus, without exhibiting any symptoms. And I think that's very scary for our patients, since they are immunocompromised at baseline, even without treatment. So I think that's a very unique challenge. So we're recommending that all our patients with CLL practice social distancing, minimize exposure, and even if they don't have to go out for groceries, they shouldn't. So I think if we can do that over the next few months, hopefully we can write this, and hopefully we will get our patients through it without having any serious complications. On the other hand, the lymphoma patients, some of them can wait to start treatment, some of them cannot. In some of those aggressive lymphomas, the treatments need to be started right away. So for those patients who need to start treatment right away, we are following them very closely for any symptoms. If they exhibit any symptoms, like fevers or a cough or any upper or lower respiratory tract symptoms, we are testing them before we give them any chemotherapy. If somebody is positive for the virus, we are not using chemotherapy for those patients, and we are trying to delay chemotherapy as much as possible. For patients already on treatment and they need to be admitted to the hospital, we are screening them with a test 48 to 72 hours prior to their admission to the hospital. And once they're negative, they can then start their treatment. So we're trying to use all of these resources that are available to us to try to minimize the risk, again, to the staff and to patients, and to prevent any complications that might happen in the future. And then one final point that I would like to make is with regards to stem cell transplants and CAR-T. Now, those can be potentially curative options for our patients. But we also realize that a lot of our patients will get extremely sick during that process. So we have multiple challenges with regards to specifically stem cell transplants and CAR-T. Now, we've also learned that the Red Cross and blood banks are being stretched. The resources are limited. The number of donors are limited. So since there aren't a lot of donors like we normally would have, getting access to blood products can be a challenge for our transplant patient, especially if they need blood transfusions and platelets. So we're trying to very specifically look at all the factors for every patient who's undergoing an autologous transplant or CAR-T cell treatment. And we're trying to select the patient who absolutely needs to proceed with it. And that patient, obviously, we are taking them to transplant. We are employing multiple testing at various time points, and we are making sure that they don't have any visitors during the stay in the hospital. And even for outpatient follow-up, it has to be a very close follow-up, ideally electronically as much as possible, and minimizing their exposure. Yeah. So have we done transplants in the last 2 months? Absolutely. We've also done CAR-Ts, and we have successfully and safely gotten patients through it. But it's challenging. It can be done, but we have to be extremely careful that we minimize exposure to our patients. And hopefully we can all get through this.
Thank you for that. Thank you for that comprehensive answer, Farooq. I think you touched upon a lot of important aspects that all of us have been paying attention to. And even though our institutions may have different ways of going around it, I think you touch upon all the important pieces. That the important overarching theme here is, if we were to be hit with a surge, we need to make sure that our hospital and healthcare system would be able to withstand it. So that's where I think the patients who are going to require inpatient care, cellular therapy patients, specifically, there was an impetus by the ASTCT to be more cautious in cellular therapy procedures during that time. I actually want to go to Dr. Flynn and kind of ask him how Sarah Cannon has handled their operations, how has the pandemic impacted their operation and workflow in taking care of patients, specifically, on the clinical trial management aspect. Because we've been getting a lot of questions from patients. We have had a lot of sponsors as well as patients who are on trials who've been worried what's going on. So please, Ian, take it away.
Yeah, sure. I mean, first of all, from a clinical side, I think we're very similar to what Farouk has just outlined. I'm struck by the similarities, even though we're very different parts of the country. Many of the things that Farouk talked about, we've incorporated in our practice here, and so it's reassuring to hear that. But specifically to address clinical trials, at least in our part of the country, we're largely continuing with clinical trials with some exceptions, right? So for patients with CLL or low-grade lymphoma that need to start on that we're going to start them on the therapy, we've tried to pause it or delay it as best we can until we're through the peak. And in Nashville, I think we're past the peak and we're starting to go on the downside. So we will likely start accruing patients again to do CLL trials. Most of them haven't been officially stopped, but or paused. But we asked the individual investigators to accrue patients, only to start therapy on patients that absolutely need it. But that we're now starting to do that again. But for some of the other trials, for the patients with aggressive lymphomas, or relapsed and refractory disease, we've tried to continue as best we can. Some of the sponsors have paused trials, and because for a variety of reasons. One, all the follow-up that has to be done, patients coming into the clinic many more times for a clinical trial than they were for a standard of care, as well as some concern about there might be some interruption in operations of some of the pharmaceutical companies and laboratories that are part of the trial. So some of them have been paused. But I would say that more than half of our trials continue, and we've been still able to treat patients on. So for instance, there's some of the CAR T-cell trials have been paused, but other sponsors have taken a different approach, and we're still treating patients on clinical trials with CAR T-cells. So I imagine that it might differ from different parts of the country depending on the risk. Thankfully, we live in a part of the country, at least compared to the Northeast, has not been struck as nearly as hard as our colleagues in that part of the country. And so we've been able to continue with some of this work, while as I'm sure centers and then talking to colleagues in New York City and elsewhere, that's really been hard to do or impossible to do. So my guess is that it varies from different parts of the country. Sarah Cannon does have operations in different parts of the country, but we're doing it on a center-by-center basis based on their local capabilities.
Thanks, Ian. I think our experience is the same. We obviously were a little worried with our expected peak to arrive last week. For our first-in-human phase on trials, specifically the bispecific monoclonal antibodies that require observation in-house, there was initial concern about slowing down enrollment on those trials because what if the COVID-19 surge comes in and the hospital is getting overwhelmed? What do you do for those patients who are on those clinical trials when bed availability becomes an issue? But clearly, we're not in the same situation as New York or Boston. And, we had 3 or 4 weeks of lead time where we could institute a lot of these workflow policies. We actually went to a 2-week on, 2-week on-site, 2-week off-site schedule in mid-March with both physicians in a very similar fashion to what was done in Italy and China, going to a Team A, Team B, and a Team C approach. It means when you're in-house, you're working really hard in the clinics as well as on the inpatient side. But then during the off weeks, you wait for the 2-week incubation period if you're got exposed to COVID-19, and you do virtual visits with patients through the virtual platforms that are available. But now that we're seeing that that plateau early on, the concerns about cellular therapies, early phase clinical trials requiring inpatient observation or hospitalization is not as big of a concern. I just wanted to touch upon, a few salient features about management of myeloma patients. We have modified our autologous stem cell transplantation schema over the past 3 or 4 weeks. We went ahead and collected stem cells but deferred transplantation or auto transplants for patients during the weeks of the surge. That means that obviously our work load will be heavier, starting early summer, but at least during the surge, if the hospital needed beds to take care of those patients, they would have been available. Or even our heme malignancy patients who get COVID-19 would potentially occupy those beds. And then where we could, we were deferring bisphosphonate therapy for bone health or denosumab infusions. We were also delaying post-transplant vaccinations for patients, as an example. We were also modifying treatment regimens where we could, if a patient needs to come in twice a week for an infusion of a proteasome inhibitor, we would just go to twice a month for during that month, as long as the disease is under control. Or, if they need to come in for IVIG, we would delay that. Or if they're getting a monoclonal antibody, we could keep them on the oral part of the regimen and then just delay the monoclonal antibody administration to avoid the COVID-19 potential, COVID-19 healthcare setting exposure to those patients. Last but not least, I want to go to Dr. Greenberger and ask him, about the role that LLS is playing during the pandemic. LLS is a multifaceted organization and has been essential to the careers of investigators like me and Dr. Wan and Dr. Flynn and others, and is a big patient advocate, as well as provides a lot of financial assistance to patients with heme malignancy. So, if you can kindly just share what you all have been doing, on all those fronts.
Thank you. On the patient access side, of course, we have an information resource center that is handling hundreds of calls from patients, asking many of the questions that you'll see on the question board about how to avoid getting COVID and what happens if you do get COVID and immune system suppression. We're getting tremendous amount of calls. We do have a urgent need fund that has been generously donated by pharma companies, and it's loaded with millions of dollars that patients can get $250 per patient. And that money will go out simply by saying, I have a blood cancer, here's my physician, and the money will get delivered. And actually there's a few other organizations that can do this. It's a very simple system to get a little bit of financial support. We certainly recognize it's a small amount, but we're hoping that it could pay some of the bills and take some of the burden off. On the policy side, we've been very active in Washington to make sure that that the blood cancer patients do not get shortchanged in this whole process, and that the hospitals, of course, are adequately equipped, not only to handle COVID patients, but certainly to handle blood cancer patients. We have 250 active grants placed around the world, and they range from supporting clinical trials all the way to basic research. We actually surveyed, we got responses from about 100 of those 250 grantees, and I could tell you that a couple of things that we've learned. One is that laboratories worldwide are closed. They are probably going to be opening fairly soon. The Australians are opening almost within a week or two. I think the folks out in California are going to be opening kind of in the July frame. In New York, I think the conditions look like probably 3 to 6 months before they open. Enrollment on clinical trials, as Ian said, really variable across the country. I was speaking to a professor at Stanford who told me basically that most of the beds in the ICU unit there's very few COVID patients. And so they are thinking about restarting in a few months and bringing patients in. On the other hand, in Boston, sweeping to the other side of the continent, 90% enrollment down in Boston. So it really varies quite a bit. And finally, I want to make the point that as it turns out, of course, inflammation plays a big role in COVID-19 patients, particularly those who wind up in the hospital and have an acute respiratory distress. And so there is sort of a hyperimmune reaction. Many of the blood cancer agents, for example, the oral therapies for CLL, the ibrutinib, the acalabrutinib, are now being tried to tone down the immune system. Tocilizumab, which was developed, which has one indication outside blood cancer, but also used to control the immune response in CAR-T, also being tried. And ruxolitinib, which is a drug for certain leukemia, again, to control the immune reaction. Beyond that, some of our investigators have actually switched their lab over entirely to move from blood cancer and taking the technology that they've used to, for example, to develop new therapeutics for follicular lymphoma and develop new antibodies to COVID-19. And finally, thinking more long-term, there are laboratories, particularly at the Broad Institute and out at UCSF, San Francisco, looking for agents that might block the ability of viral proteins to engage human proteins on the surface of these respiratory cells to block that interaction. And there are a whole bunch of candidates. So I think that those agents have a long way to go. I think that the agents that have been approved for certain blood cancers, where we know that there's a safety, we understand the safety of the molecule well, can be applied to control the immune reaction, all the way to new experimental therapies that are going to take quite a while to see whether they can be developed for COVID. I do think that the COVID-19 situation, is, at least certainly in New York, and that's where I'm located, is not going away very fast. And beyond that, the possibility of reinfections or additional wave of infection means that we're going to have to deal with this probably on a long-term basis, or at very minimum, be prepared for a spike if and when it happens, whether that be in the hospital setting, or in the laboratory setting.
Thank you, Lee. I'm actually going to ask Zainab to elaborate on a couple of things here. And I'm feeding off of some of what Lee has just said. How confident are we that we have the right tests for COVID-19? Can we confidently assess whether someone who got COVID-19 has cleared the virus or has become immune to it? Can you kindly elaborate on some of those questions? If you get an infection, how do we know that the patients are all better and are not still transmitting the virus to other people?
Sure. So the sensitivity of the test that we know best is up to 70% in a situation where the nasopharyngeal swab is done with correct methodology. Having said that, we know that the decreased sensitivity allows patients to go undetected and can potentially still be infected with COVID-19. Talking about patients who have turned positive by that test that we have available by PCR method, we know that individuals can, after recovery from the symptoms, can shed the virus for a long period of time. We know from other respiratory viruses that immunocompromised population tends to shed the virus for a longer period of time. And Dr. Shah, can you specify that long period of time? Is it days, 2 weeks, or can you kindly be a little specific? So what I was going to say that when we already know the data in terms of SARS-CoV-2, that the virus in normal host, meaning non-immunocompromised patient, can shed for up to 6 weeks with the recent data that we have seen. So having that information, we can assume that there would be longer in our patient population. Now, we know that there is a huge knowledge gap. We do not know if we can only find out if we have a good number of patients who are tested weekly to see when does the actual shedding stop in immunocompromised population. So the issue of testing and prolonged shedding stays, and when do we bring those patients back to safely to resume chemotherapy is a question that still needs to be answered. And we decide on case-by-case basis at this time, because there is as we know that there is no normal safe time period that we can say that this is a good time to reinitiate therapy.
Okay, and Zainab, if you can also share with us the landscape of clinical trials that are being done for COVID-19 disease, both preventative, antiviral, or even, for the sequelae of disease, as a response to cytokine storm or, the pulmonary disease picture. If you can kindly just touch upon that.
Certainly. So we know that the arena of clinical trials is wide open for COVID-19. If you look it up, there are going to be, last I looked, there are more than 200 clinical trials. So we have to be good advocates of good agents which would be useful for the treatment of SARS-CoV-2 infection. We know that there are clinical trials looking at agents which are geared towards treatment after exposure, so preventing the development of infection. Antiviral agents that have been planned to be studied in AML patients now be moved towards SARS-CoV-2 after exposure. We know that another agent which was being tested for parainfluenza virus infection called DAS-181, clinical trial for that agent is also being started in the U.S. The third antiviral agent, we know remdesivir, is already under investigation. However, the site availability for different places may not be available easily because of the study drug limitations, shortage, And in terms, as we've gone to know the disease, we know that after the initial infection, a week after, people can do poorly if the immune cytokine release storm sets in, classically starting in the second week, where people seem to do worse in that time period after the initial infection. So anti-inflammatory agents such as anti-IL-1, anti-IL-6 receptor blockers, anti-IL-6 blockers, namely tocilizumab, anakinra, cetuximab, are being investigated in clinical trial setting to see if they can be utilized to decrease the severity of inflammation and improve outcomes in this patient population. Similarly, myocarditis has been associated with COVID-19 severe disease, where these anti-inflammatory agents are being investigated. We know that convalescent serum is being utilized in clinical trial setting as well. So there are many, many approaches that are being evaluated to improve the outcomes associated with the disease, but we do know that the clinical trials do take time. And most of the data that we have received out of China, Italy, has been case series in most cases.
Okay, thank you. And speaking of agents that may have activity in COVID-19 disease, I wanted to ask Dr. Zawan and Flynn about BTK inhibitors and some of the anecdotal data that we're hearing, in Waldenström's disease. In fact, I believe Steve Treon just published a case series in Waldenström's patients who were on ibrutinib and their experience with COVID-19 and saying, that there might be some mechanistic benefits in dialing down inflammation in the pulmonary epithelium in those patients. Can you kindly, share your experience or thoughts?
So I can just start off by saying that I agree with everything that Zainab said. I think there are two ways to approach this issue. One is the drugs that are targeted towards the virus. And I think that's a very critical part. So we need to start those early. We need to start treating patients who may not be very sick, and hopefully we can prevent them from getting sick. And I think the next approach is all of these other agents, and there's so many of them that are being evaluated, which are actually providing supportive care by not necessarily killing the virus, but by reducing the inflammation and protecting different organs. So this ibrutinib paper that you were referring to, and I think similar BTK inhibitors are already in trials using these agents in patients with a lot of pulmonary symptoms or lung problems, and hoping that that would reduce the inflammation and that would make our patients recover faster. So that's definitely very promising, very exciting. Another thing that we have seen, which again is being debated in the field right now, is that some of our patients with the COVID-19 infection, and I just had to address this issue a few days ago, so I'll share this personal anecdote. So my patient was on a clinical trial with ibrutinib, and she developed COVID-19 disease, and within literally hours, her oxygen levels dropped tremendously, and we had to put her on a ventilator. So the big dilemma is, should I continue on ibrutinib or should I stop the ibrutinib? So I don't think that there is a right or wrong answer, because technically this would be considered a side effect. So I would have to stop the drug based on the trial parameters. But there is some justification to continue the drug, because that can reduce the inflammation in the lungs, and she will potentially can recover faster. The other thing that I feel is also very important is that the COVID-19 patients are being reported to have blood clots in the legs and also in the lungs. And the BTK inhibitors also has some blood thinning properties. So there might be some protective benefit through that mechanism. Will that be enough so that we don't have to use blood thinners in those patients? I am not sure. I think these are exactly the questions that need to be answered in clinical trials. But I felt that this was such an interesting observation, that there are so many different drugs out there that we really have to decide at this point, where do we focus our energies on? Where do we focus our resources on? We have treated more than 50 patients at our center with remdesivir, because the idea is that if we stop the virus from getting worse, then we can prevent the complications. Will that be the approach moving forward? Or will we use selinexor, because that's in clinical trials? Will we use acalabrutinib? Will we use ibrutinib? And so many other drugs that are very promising and that have a very sound preclinical rationale of why we should use it. But I think at this point, the resources are really limited. Staffing is limited. And obviously, we want to do the best for our patients. So we have to just guess and hope for the best.
And Ian, what are your thoughts?
I think, again, similar to Farouk's, I think that there's a number of anecdotal reports that, very compelling anecdotal reports, patients heading to the ventilator, taking one of the BTK inhibitors, maybe transiently going on the ventilator and coming out, and then discharged soon thereafter. I mean, some of these things are amazing, but like all the anecdotes, they're hard to know whether the person would necessarily have a similar course. We're seeing this debate in the, now with hydroxychloroquine, does that help? There was someone who said that it couldn't hurt. A report, I think, out today suggesting that there's at least a population of patients in a retrospective analysis that they had a worse outcome with it. So I think there's a lot of that we don't know, and they're very important scientific questions. I think, as mentioned earlier, there's sort of, you can treat the virus, or you can treat the virus's reaction, your body's reaction to the virus. So some of the things we're hearing about, the BTK inhibitors and other drugs, are designed to dampen the inflammatory reaction and keep some of those bad pulmonary symptoms and progression of the disease. And so that's the hypothesis there. I certainly wouldn't put a patient on a BTK inhibitor outside of a clinical trial for treating COVID. I know that there's a lot of debate for patients with lymphoma and CLL that are already on a BTK inhibitor, as Farouk was mentioning. Should you take them off? Different institutions have different approaches. Personally, I would be afraid to take someone off if they've been on a BTK inhibitor for very long, because sometimes you get that withdrawal inflammatory reaction that occurs in patients that have been on it for a long time. And I could imagine you might actually make things worse. So I think we all have to admit we don't know what the right answer is to these things, and try to study them in a controlled manner. And so hopefully 3 to 6 months from now, we're smarter than we are today and have a more appropriate approach.
Okay, thank you, Ian. I'm going to start going to some of the questions that are coming through, and I'll direct them to our esteemed panel members. If there are some that I can take on, I'll take them on. I think there was a question from one of the patients or attendees, what do we mean by shedding the virus? The ability to infect others up to 6 weeks. I think we direct this question to Dr. Shahid, if she's still on.
Certainly. So shedding the virus means that after recovering from COVID-19 illness, the symptoms have resolved. However, if you were to repeat the test by the PCR method, it continues to stay positive. What that positivity truly means, it is unknown. Does it mean that we are still infectious and passing on the virus to others, versus this is the remnant of the RNA material that we are seeing in the nasopharyngeal area? Or does it mean that the virus can infect others? It has not giving you symptoms, but it's persisting. Now, short answer is we don't know what that truly means. We also do not know what it truly means, whether we can restart chemotherapy at that time or not. Or can the patients be coming back to the medical offices without any precautions? So there's a more unknown with this rather than we know what we truly know. But we have observed that this virus can continue to be present in the airway for a long period of time. Okay, and then
for Dr. Greenberg, do you have to have blood cancer, or can you have another cancer to get the LLS grant?
Well, all of our grants at the moment are focused on blood cancer. I know some other organizations that have more broader scope are funding work outside of blood cancer or outside of their mission. But at the moment, to get a grant from us, it has to be blood cancer related. That said, there are at least 4 or 5 different agents in blood cancer that are being translated over to COVID. And some of those trials are actually even being run by our blood cancer doctors that we're supporting.
Okay, and then this next question is for Dr. Awan. I'm scheduled for a stem cell transplant this summer. Will the threat of COVID-19 make me more or less susceptible? Is there any more of a danger than any other infection?
That's a very important question, and I think we have to be clear what kind of a stem cell transplant we're talking about. So if they're talking about an autologous stem cell transplantation, That was briefly what I discussed earlier. The risk of infections is definitely higher in patients, not just during the chemotherapy period and right after, but even for the immediate post-transplant phase. I would argue that maybe up to 3 to 6 months after the transplant, they would still be considered immunocompromised, if not longer, even though their numbers might have recovered by then, but the T cell function and the other immune cells in the body take a long time to recover. So definitely anyone who's going through a transplant, who has to go through a transplant, we have to be extremely cautious with them. We have to take very close care of those patients. We have to make sure that their exposure is minimized. We have to make sure that there is not an issue with the availability of blood product in our area where we're planning to do this transplant. So I think those are the precautions that we would have to take for those patients. So if you can put off the transplant by a few months safely, then I would probably go with that. Similarly, on the allogeneic transplant side, that's an even bigger undertaking. But I know that for a lot of those patients, especially patients who have an acute leukemia or who have really aggressive lymphomas, without an allogeneic transplant, they may not have good disease control. So we have to control the disease. And we also realize that the complications from allogeneic transplant and the immune suppression that is needed will go on for months and years following the transplant. So I think it will impact a lot of our patients who have already gone through a transplant and are being immunocompromised, and even patients who are going through an autologous transplantation for myeloma or for lymphoma. I think all of those patients, in my opinion, would be considered high risk, and I would be very, very cautious with those patients. But I would not necessarily delay all of those transplants. I would do it on a case-by-case basis.
And the next question, thank you, Dr. Wan, for Dr. Flynn. Is there anything I can do to boost my immune system to help prevent COVID-19?
I think that some of the just general advice about improving your health applies here. So, the experts in this field will say you want to make sure you are getting plenty of sleep, you're eating right, you're taking care of yourself as an overall health, not just specifically for COVID-19. So so exercising and doing other general health measures are probably the best you can do. There's no simple pill you can take. There's no simple medicine you can take that's going to improve your immune system, help you fight off COVID-19. But general health measures will. Now there are there's exceptions to this rule in the case like patients who have low white counts occasionally use growth factors to bring up their white count, their neutrophils to help them fight off infectious complications. By and large, giving patients IV immunoglobulins probably won't help in the setting of COVID-19. We know from the CLL literature that that patients who have low antibody levels, low immunoglobulins, that if we give them and they have recurrent infections, that we can prevent some of these recurrent infections by giving them IVIG on a monthly basis. But if we look at that data carefully, the people but it's not the viral infections that we're preventing, it's the bacterial infections. So cases such as a viral infection like COVID-19, I wouldn't expect it to be prevented by giving people IVIG.
All right, so thank you, Ian. The next question I'm going to ask Dr. Awan again. I am this is from a patient who has AML and is a 10-year post-allogeneic stem cell transplant survivor. And the question is, am I at the same risk for COVID-19 as an immunocompromised blood cancer patient? Or is my risk any different and comparable to the general public?
Well, I think that's a difficult question to answer. If you're 10 years out of a stem cell transplantation, there's two assumptions I would have to make. One is that you're probably off of immune suppression, and your immune system is fairly healthy. Now, that's also assuming that you don't have any that purpose. So if you're not on any immune suppression, 10 years out, you would be probably considered cured. And I would expect your immune system to be robust. And hopefully, unless you're having recurrent infections or regular infections, I would imagine that your risk would be fairly similar to a similar patient population, although I would also be cautious a little more so than our normal patients. And I would also echo another point that Ian just made. I think the IVIG role is being discussed a lot in our patients. Specifically, can they provide our passive immunity, and can we use them more to protect our patients? And the answer to that is, like Ian said, I think the role is limited. It's to prevent secondary bacterial infections. And sometimes people start off with a virus and then they get a bacterial infection on top of that. And percentage of our patients with COVID-19 do have co-infections. So they have bacterial and viral infections. So I think they might have some role, but I would also argue that getting IVIG for a lot of patients mean getting to a healthcare facility, a clinic, or a hospital and staying there for a few hours, being exposed to more personnel. So the benefit and risk is you have to weigh that with IVIG. So in some patients, yes, I think they might be beneficial, but for the vast majority, it may not be very helpful.
Okay, thank you, Dr. Awan. And then, I'm going for the last question here, Dr. Greenberger. If you can kindly, again, highlight the financial assistance available through LLS for heme malignancy patients in general, and then the COVID-19 pandemic affectees.
Right, happy to do that. So I actually just went to the website myself to make sure that I've got this exactly right. We are offering a $250 stipend for patients with non-medical expenses, such as food, housing, utilities, etc. You do not have to have COVID-19 diagnosis, and there's no income criteria to qualify. If you simply go to our website, lls.org, you'll find on the front page of that website, you click on the button, it'll take you to a button, it'll say apply here, and you could simply apply. The money is loaded in and available, so it's there for any eligible blood cancer patient waiting for you.
Thank you, Dr. Greenberger. Unfortunately, we have run out of time. We have had a fantastic discussion from all the panelists addressing all the key questions that were asked of us. I would like to thank our audience for being engaging, for attending, and really testing us and our knowledge. I want to highlight the fact that most of the things about COVID-19 are not known. Our collective global knowledge of this disease is only a few months old. Dr. Shahib had laid this out at the very beginning, that our knowledge timeline for COVID-19 started in October of 2019. So we're hardly 6 months into this. Our knowledge is only 6 months old, and we are still in a learning phase. But all the questions that you pose to us also help us think about those things that we were previously perhaps not thinking about. I would like to thank Cure and our sponsors, Janssen and Pharmacyclics, for making today's educational webcast possible. Thank you all for joining us. We'll see you next time. Goodbye.